Hello everyone, in this class we'll learn about alveolar ventilation. Anatomical dead space. It is the volume of air present in the conducting zone of the respiratory passage, which is from nose and mouth up to the terminal bronchioles. It is the respiratory system volume exclusive of alveoli. Here there is no exchange of gases. The normal value of anatomical dead space is approximately the body weight in pounds. For example, a man who weighs around 150 pounds, that is 68 kgs, only the first 350 ml of 500 ml of inspired air, inspired with each breath at rest, mixes with the air in the alveoli. That is, 150 ml of the expired gas is from the dead space. Physiological dead space and total dead space. Physiological dead space, it includes anatomical dead space plus volume of air in the alveoli which does not take part in the exchange of gases, that is wasted ventilation. It is the volume of gas not equilibrating with the blood. Note that clinically anatomical and physiological dead spaces are same in healthy subjects. If ventilation and perfusion are not in equilibrium, then only they differ in volume. Some of the variation in dead space. Physiological causes. Dead space is more in case of males. The dead space increases as age increases because the inflated lungs pull the airways, increasing the airway diameter. Then dead space is directly proportional to the body weight. Some of the pathological variation are emphysema. The loss of elasticity of lungs decreases the elastic recoil, produces hyperinflation of the lung, which causes increase in dead space. Bronchiectasis, it is associated with dilated bronchi, leading to increase in the dead space. Alveolar ventilation, it is the amount of air ventilating the alveoli per minute. Hence, alveolar ventilation can be given as tidal volume minus dead space into respiratory rate. That is, alveolar ventilation is equal to 500 minus 150, where 500 is tidal volume and 150 is dead space, into 12 will give you 4.2 liters per minute. So that is the normal ventilation. Physiological significance of alveolar ventilation. Respiration involves the gaseous exchange of oxygen and carbon dioxide by diffusion between the alveolar and pulmonary capillary blood. So maintenance of volume of alveolar ventilation is very important. In tachypnea, that is where there will be rapid shallow respiration, alveolar ventilation decreases, though the pulmonary ventilation remains normal. As a result, less air is available for exchange. In slow, deep respiration, both alveolar and pulmonary ventilation are normal. Coming to ventilation perfusion ratio, it is the ratio of alveolar ventilation to pulmonary blood flow. As alveolar ventilation is 4.2 liters per minute and the pulmonary blood flow is around 5.5 liters per minute, then ventilation perfusion ratio is approximately 4 divided by 5, that will be 0.8. The total ratio is not important. More important is that whether this ratio is present uniformly throughout the lungs for proper oxygenation. Some of the factors which are affecting ventilation perfusion ratio. Physiological causes like the effect of gravity. Ventilation perfusion ratio are high in the apical portions of the lung and less at the base. Some of the pathological causes, like all the factors which cause uneven alveolar ventilation or non-uniform blood flow to the pulmonary circulation, will alter the ventilation perfusion ratio. For example, bronchial asthma, pneumothorax, emphysema causes uneven alveolar ventilation, whereas Fallot's tetralogy, pulmonary embolism, causes ununiform pulmonary blood flow. Clinical significance. It is said that high ventilation perfusion ratio at the apices account for the prediction of tuberculosis for this area, because high alveolar PO2 provides a favorable environment for the growth of tuberculosis bacteria. Physiological shunt and its significance. When ventilation perfusion uh, the ratio of alveolar ventilation to the blood flow below the normal, there is inadequate ventilation to provide oxygen needed to fully oxygenate the blood flowing through the alveolar capillaries. Therefore, a certain fraction of venous blood passing through the pulmonary capillaries does not become oxygenated. This fraction is called as shunted blood. Although some of the bronchial vessels, that is bronchial arteries, branches of thoracic aorta, enters the bronchial vein, some enters the pulmonary capillaries and veins bypassing the right ventricle. Blood that flows from coronary arteries into the left side of the heart. In these two exceptions, a physiological shunt is created and the blood in the systemic arteries has a PO2 about 2 mmHg lower than that of the blood which is equilibrated with the alveolar air. Greater the physiological shunt, the greater amount of blood that fails to be oxygenated as it passes through the lungs. So, so this is the partial pressure of different gases in inspired air and expired air. The oxygen partial pressure is 158. By the time it reaches in the expired gas, its concentration reduces to 116 mm of Hg. The carbon dioxide levels drastically increases, whereas nitrogen partial pressure remains constant even in the alveoli. In the alveoli, partial pressure of oxygen is 100 and carbon dioxide is 40 mm of Hg. And in the arterial and venous blood, the oxygen partial pressure of oxygen is around 40, and by the time it reaches the left heart, the partial pressure is around 95 mm of Hg, and it is not 100% saturated as it is in the alveoli because of the physiological shunt, where some of the the venous blood is not oxygenated by bypassing uh, the respiratory system. And in the tissue, the partial pressure of oxygen is around 40, carbon dioxide is around 46 and 46 mm of Hg. That is in brief about the alveolar ventilation. Thank you.